Hi, I'm Rod Rorick. I'm one of the co-founders of AIRS Foundation, a nonprofit organization that actually helps patients with breast reconstruction to support them and to provide funding for breast reconstruction. We are very, very pleased today to have an incredible radiation therapist with us today, Dr. Asal Rahini, and she's going to discuss with us, the living with cancer during COVID and what do you need to know about radiation treatments during this time. Dr. Rahini is a clinical is actually a associate professor of radiation oncology at UT Southwestern Medical Center, and that's all. Welcome.
Thank you. Thank you for having me.
You bet. How are you doing?
I'm doing good, staying safe and healthy, and trying to make sure everyone around us stays safe and healthy too.
That's right. That's right. Well, welcome. It's a real honor to have you with us. So let's talk a little bit about the landscape. The breast radiation landscape through this COVID pandemic, and what you're doing and how you're helping our breast cancer patients.
Sure. Yeah. So I think a lot has changed in the landscape of breast radiation. I think if you go back over the last 10 years in general, a lot has changed in the landscape of radiation oncology. But actually, what's going on now is the COVID pandemic is actually accelerating that.
Right.
And what I mean by that is one of the themes in radiation oncology has been trying to reduce the number of treatments that people actually have to come in here for the radiation treatment. So reducing the number of treatments.
And this is before COVID.
This is before COVID.
Good. So we're accelerating. So there's some good. There's some good things.
So it's good. However, every subsite in radiation oncology is a little bit different. We treat obviously brain tumors differently, lung tumors, breast tumors. Right. All of these tumors are treated differently. In the breast radiation, there has been some studies that have actually showed shortened courses of radiation, but it hasn't quite picked up everywhere yet. And so I think with the COVID pandemic, one of the good things that will come out of this is that I think that this will really accelerate most practices to kind of be forced to kind of treat people in these shorter courses of radiation.
And the outcome is the same, the safety and outcome.
Yeah. So there's obviously different situations and different clinical scenarios. But there's been like two manuscripts that I've really enjoyed reading regarding breast radiation. And one of them is a COVID-19 pandemic workforce that was put together, like a consensus that they put together. Another one was a manuscript that came out from Memorial Sloan Kettering. And basically what they did in these manuscripts was put patients in different tiers. So there's like a tier 1, tier 2, tier 3. And it's basically on kind of like the urgency of when patients need to be treated. Okay. And so essentially the tier 1 are kind of like the really high risk patients. The tier 2 are the intermediate risk patients, and tier 3 are really the early stage breast patients. And what they've done in these manuscripts is they've kind of outlined how quickly these patients should get treated, and also in which circumstances we can actually shorten these treatments.
And this will be valid even after COVID, correct?
Yeah, and I mean, I think part of this was valid even before COVID. It's just like, for example, in Europe, they were kind of doing some more of these shorter courses a little bit more prevalently than we were in the US. So there is data to support all of these different ways. It's just in different geographical areas, not everybody has actually done these shorter courses of radiation.
So I guess if I was a COVID breast cancer patient, or I would say that I'm not getting shortchanged, I'm getting the same therapeutic endpoint, correct?
Is that right? Absolutely. So yeah, so that's very important, is that everything that we have that we're going to describe right now has been proven, has been shown. There's been clinical trials that have proven. And so basically the outcomes should be the same. It's just a little bit of a different approach to make it more convenient for patients and having them to come to the radiation oncology less, or potentially delaying their treatments. And so that we can kind of utilize some of the hospital resources where they need to go, but in doing it in a way that it's not going to reduce the outcome for people.
So you were actually starting to do this before COVID, or these manuscripts were actually, or this use was this being done in Europe before?
Yeah, so I mean, there's different clinical scenarios, and a lot of these like shorter courses of radiation have been done here in the United States. I mean, we standardly do these in our own practice, and a lot of it has been done in Canada and in the United Kingdom.
Okay.
And I mean, it's been very prevalent. It's just like I said again, different practices may or may not do these for different reasons. Maybe it could just be that they don't have the experience to do it. It's a change, right? Anytime there's a change,
Sure.
sometimes it takes time for things to change.
Yeah. Plus, also the radiation center at UT Southwestern is excellent.
Thank you.
I mean,
Thank you. We pride ourselves on
Pierre's a
trying
good friend of mine. So he's awesome. So tell us a little bit more about, the delaying of the treatment with endocrine therapy. Can you talk about that too? Because I get a lot of questions about that.
Sure. So these 3 tiers I was talking about, the tiers that really can potentially benefit from having this delay in radiation is really going to be like the tier 3, which is the low risk breast cancer patients.
Mm-hmm.
So when we talk about low risk breast cancer patients, these are patients that are estrogen positive, estrogen or progesterone receptor positive. So their tumor cells have estrogen receptors on them. They're typically like lower stage patients, like stage 1. A lot of them will have lymph nodes negative, or they could be stage 0 breast cancer, which means that they have ductal carcinoma in situ, which means that it is not invasive cancer. So in these patients, these are the patients that we can safely delay radiation for, or potentially even omit radiation for. And again, these are all proven trials that have happened. And now it's just because of the COVID pandemic and because the hospital resources are kind of stressed, it's important that now we can act on these types of clinical scenarios.
Okay.
So regarding the patients that can potentially eliminate radiation, those would be patients that are 65 or older, have the ER estrogen positive cancers, stage 1 lymph nodes are negative based on mammogram or any kind of imaging that they've had.
So that lower risk tier group.
Yeah, so the lower risk. So those patients after lumpectomy, as long as they take the 5 years of either like tamoxifen or anastrozole, which are some of these hormone blocker oral medications, as long as they commit to taking that for 5 years, and they have seen a medical oncologist, and the medical oncologist believes that they would be able to tolerate, and then they don't have other risk factors that would make them not a good candidate to take these medications, then these are patients that could potentially eliminate radiation.
Right. And I just want to, and I think also the great thing about the UT Southwestern Breast Center is that all of these decisions are made in combination with all the breast experts, yourself, breast cancer experts, breast surgery. And I think that's the beauty of being in a breast center, certainly like, UT Southwestern's breast center, which is like top rated. So is that correct? Right?
Yeah, no, absolutely. And I mean, I think a lot of these decisions, it is really important that you have your surgeon that is involved, the medical oncologist, the radiation oncologist. So really you're getting kind of a holistic approach, because, the thing is also going to be different situations are going to be different, and also different geographical locations in the United States may be handling this a little bit differently, dependent on how prevalent COVID is in that region. So places that don't have a lot of COVID, they may have different ways that they are going about this. But so basically these are some patients that could potentially eliminate radiation, and the survival is the same for those patients. So that's very important.
What about after surgery? How long can you delay?
So typically what we have done is standardly before COVID, we would always try to treat between 6 to 8 weeks starting radiation after surgery. Again, for these hormone positive patients, there have been studies that actually have shown that you can actually postpone starting radiation up to 20 weeks.
Right.
Now, that is with the caveat that you are starting these anti-hormone treatments.
Right.
So, because typically a lot of times we would just start radiation and we don't start the anti-hormone treatments, and then we try to start the radiation within a 6 to 8 week time frame. So if your medical oncologist thinks that you would be a good candidate to actually start this, what we call endocrine therapy or this anti-hormone therapy, then we can potentially postpone the start of radiation to 20 weeks until the COVID pandemic is under a little bit better control. And so preventing people from coming in and out of, the radiation oncology suite. So that there are several studies that have shown that would be a reasonable approach. Again, that's with the caveat that they are on endocrine
Right.
therapy.
And of course, every patient's different, and we're just giving you general
Right.
information
Yeah.
because, they're going to come see you. They're going to present it to the team at the breast center at
Exactly.
UT, so Southwestern. So, yeah. So, I mean, but that's good advice. I must say that's very comforting, I think, to a lot
Yeah.
of questions that we get from our heirs patients, because we are coming through this, and now we'll hopefully be coming out through this
Yeah. I
window.
think we're starting to see light at the end of the tunnel.
Yes, exactly. So, what do you tell your patients they should do to protect themselves? Because obviously, they're going to have irradiation. You're going to have a lot of
Yeah.
touch and
So exactly. So, I mean, I think it's really important that there's processes that are set up in the clinic or any hospital that you go to,
right,
which at this point in the United States, many of these hospitals have taken appropriate measures. So, we tell people when they come in, wear a mask.
right, very
Masks
important.
are very important, because if you want to prevent the spread of this, and also you don't want to be breathing other people's breaths, I guess you can say. So wearing masks, washing your hands consistently, really trying not to touch, surfaces that are being touched very often, like countertops
Right,
where receptionists are.
and
Um,
social distancing continually.
yeah, social distancing, staying 6 feet away. Some of the other things that we have implemented in our clinic is we have really tried to minimize the number of visitors that are coming into the clinic. So we've minimized it to no more than one visitor because we do
So
want.
basically, there's nobody in the quote unquote waiting or reception area, or
Right. We're really trying to minimize how many people are in the waiting and
right,
reception area. We've
right,
given patients the option to sit in their car,
yeah,
and when they're ready for their radiation treatments, we can call them
yeah.
via cell phone. So these are all kind of measures to try to really prevent the waiting area and to not have more people that need to be in these particular areas. Um,
And you do this standard CDC updated guidelines and temperature of
Yeah, so everyone that
everybody.
comes in has they get a temperature check. There are questions that are asked of them pertaining to any particular symptoms that they've had, any recent travel, specifically any travel to, hot spots,
Right.
um, and that type of thing. So, I think that,
What about your staff? What about you and your staff? You do the
we
same
have this
protocol every day?
same every day.
Yeah.
Temperatures are checked,
I think,
same
yeah,
questionnaires every single day.
yeah,
And, if any of us develop a temperature, we are staying home. We are not coming in.
yeah.
I
I
mean,
agree.
I think it's very important that everybody understands that if you develop a temperature, you
You're
need
home.
to stay home and call your doctor, and they can give you some more information on what to do.
Right, exactly right. And I think people need to know that it's really to protect them, protect us and our staff. And I think you have to have the same protocols, and we record them all daily. And we do it coming in, going home, and that's good. So tell us about when radiation can be omitted. What like when do you tell your patients? Obviously without COVID. I mean,
Yeah. So, I mean, I think that really it's going to be these patients with the early 65 or older with stage 1 estrogen positive breast cancer. And then there are going to be some situations for patients that have DCIS, low volume DCIS. What I mean by low volume DCIS is like 2.5 centimeters or less. They have low grade estrogen positive DCIS. This is another situation in which you can consider omitting it, but you're going to have to take the patient's age into account, because patients that are younger are also going to have a lot longer to live, which means higher number of years to have a recurrence. So these are all things that are going to need to be discussed with the patients, but certainly those patients can also be delayed in starting their radiation, and then potentially they can be omitted.
yeah. I have a great question here, Asal. What about when they're getting their radiation treatment? And let's just say they're working. Should they work or should they stay home during their 6 or 8 weeks of radiation? That's a good question.
Yeah, so I mean, I think patients can still work during their radiation treatment, and they still need to take the appropriate precautions. Obviously, a lot of us are under these stay-at-home orders, so many people are still going to be working from home, but usually people are still able to be completely functional during breast radiation and continue, all of their daily activities that they normally were continuing. So, I mean, and we want people to still work and still be functional.
Okay. That's a great question. So a question always comes up, okay, which in radiation without COVID can be safely, truly delayed? Just normal.
Yeah.
Just say, you're very busy. I've had my master.
Yeah.
I just don't want to do it. What's my window?
Yeah. Well, so it comes back down to these, again, estrogen positive patients. A lot of these estrogen positive patients can be safely delayed. Even before COVID, there were certain patients that we would just start them on endocrine therapy, this anti-hormone therapy, and then they would be on this for 4 to 6 months, and then they could be delayed in having their surgery. And basically what that would do would basically just shrink the tumor a little bit,
okay,
and kind of keep it under control from growing, bigger. And then in the setting that we normally would have done that for was situations where maybe the surgeon wanted to debulk the tumor or make the tumor a little bit smaller in order to have like a better cosmetic outcome or to basically save the breast. So now we can use that same approach and allow a wider array of estrogen positive patients to go about that approach if the surgeries are still being delayed in some states.
Just give me a range of like how many weeks can they delay with?
So
in general for that group.
In those cases, there's literature to support anywhere from up to 6 months to 12 months, but I think we have been doing it no more than 6 months. So, we can delay it for months for estrogen positive tumors. Of course, not the ones that seem to have a lot of lymph nodes or an inflammatory breast cancer. We wouldn't do that for an inflammatory breast cancer, but ones that may have like 1 or 2 lymph nodes that don't seem to be very aggressive, then that would be a very reasonable approach.
Okay, it's great. We get that question a lot. So what about some other examples of breast radiation that's commonly talked about, hypofractionation?
Yeah, let's talk about.
Tell us about that, because I get that a lot.
So hypofractionation, that is a term that you will hear a lot of radiation oncologists say. And basically what that means is basically shortening the number of treatments that you have to have for radiation. So standardly, 50, 60 years ago, we would do whole breast radiation in a 6-week course. In hypofractionation, there has been some newer regimens that have come from Canada and from the UK, and they have shortened the radiation to anywhere from 3 to 4 weeks. And so when we say hypofractionation, we are really talking about these regimens.
So you're talking about shortening, you're getting the same amount, but you're shortening the time period?
Yeah. So
it's hurt the tissue anymore? Or?
So no, it actually, the outcomes seem to be the same. The local recurrence is the same. The survival is the same. And actually, the cosmetic outcomes are a little bit better with the hypofractionation.
Why doesn't everybody do that?
I can't speak for other practices, but some people just may not have that experience and may have not been trained with that. But it is our organization, ASTRO, which oversees all the radiation oncologists in the United States, has stressed that this should be a new standard for patients that have to have breast cancer,
in the United States.
When we're treating lymph nodes, there are other regimens that have been tested, and there are some multiple clinical trials that are ongoing right now doing kind of these hypofractionation regimens with the hypofractionation courses that we talked about, but those are ongoing. But there has been some preliminary evidence that we can also do that for post-mastectomy situations in which we have to treat the lymph nodes as well. But yeah, it's a standard. It should be a standard treatment, and it is as effective as doing the 6-week course. And I think even more in the COVID pandemic, it's more important that we are offering these shorter courses.
So you give the patient the option to do that, or you just say this is really what we prefer?
So if patients are eligible for that, we will basically give it to them.
Okay.
That's kind of our standard fallback.
Okay, now
Sometimes,
go ahead. I have another question here about radiation. So, okay, I've done my radiation. You've done it beautifully, and now I need to get my breast reconstruction. So, what? And of course, I know it's a team at UT Southwestern. But tell me, so let's just say that patient isn't part of your team. I mean, she's part of your team, but she's going to have your breast reconstruction done in Oklahoma or at home. So, what do you tell them? How long should they wait, and why to get their breast reconstruction?
yeah, so well, what we have done with the plastic surgery group here at UT is we have waited for about 6 months.
Six
Um,
months for
yeah,
any reconstruction. Yeah.
yeah, for 6 months to get reconstruction. And really that is so that patients can, skin is going to change after you have radiation. You may
Yeah.
develop a little bit more fibrosis or thickening of the skin or changes to the skin or changes to the size of the breast. So we want some of those changes to actually set in
Right.
before they move forward with their reconstruction. And then that way, the reconstructive surgeon, the plastic surgeon, can have a better sense of what they're going to work with, and then kind of have better outcomes when it comes to symmetry. So making sure that one breast looks similar to the other breast, because you don't want to do a reconstruction right away and then the other breast
Yeah.
starts shrinking. So 6 months is what we have done here in our institution.
Yeah, I think that's very conservative. Obviously, as a plastic surgeon that done a lots of breast reconstruction, I think that's very safe. I really, some people really want to go sooner, but I agree with you. I think the longer you wait, especially 6 months, the better it is, especially if you're doing a complicated breast reconstruction.
Yeah. And you just want time for that tissue to heal before you guys start doing surgery.
Yeah, I agree with that. So, okay, what about some of the other new and innovative things you're
Yeah.
doing in the breast center, and certainly that you're doing in your department at
Yeah.
Southwestern?
So the other thing I think we need to talk about is partial breast radiation.
Right.
Yeah.
Excellent.
And so one of the other things that some of these consensus guidelines have come out with are, well, these manuscripts I was talking about, is really trying to offer partial breast to patients that are candidates for it, even more so now than before COVID, because then we can really shorten the course of radiation. We can shorten the amount of radiation that is being given to the normal breast, and then also the number of trips that people have to come back. So anyone that is a candidate for partial breast should be given that option for partial breast. There's different ways that partial breast can be done. One of the more common ways has been with something called brachytherapy, in which an applicator is actually, catheter is actually placed into the breast, which is kind of invasive. And, you have, sometimes surgeons will go back to the OR, sometimes they can do it in the operating room. So one of the things that these guidelines has stressed is that maybe we shouldn't be doing brachytherapy during the time of COVID, just because it's going to take more resources to do that, and then there's potentially a higher risk of infection, and we should maybe hold off on doing these brachytherapy techniques for breast cancer, because there are other options. There are other more non-invasive options to doing partial breast radiation rather than the brachytherapy, just for this small time period of the COVID pandemic.
That's great. That's great.
Yeah.
So, Dr. Rahini, what message do you have for our patients during COVID, and now that we're coming out of COVID, that I think should give a level of reassurance, from you, from your breast center at Southwestern?
Yeah.
What advice would you give them?
So, just basically based on my experience and what I have been dealing with my own patients, I think that this is a very nerve-wracking time for humanity in general, but even more so for patients that are actually dealing with cancer, because in their mind they may have thought, by now all their treatment would have been done, and then there's delays and kind of there may seem to be all these roadblocks. But I think that the societies have done a pretty good job in guiding all of the breast cancer physicians and kind of helping them make some new guidelines and trying to steer clear of this COVID pandemic, and at the same time not compromising people's outcomes. And that is really the priority of every oncologist, is not to reduce the outcomes of patients of how they're going to do. And we want the survival to be the same. We want the local recurrence to be the same, but these treatments may take a little bit longer than before this whole COVID pandemic. But ultimately, all of these decisions shouldn't change the final outcome. And so that is the thing I want to stress. And I hope that that message can really kind of reduce some of the anxiety that women may be feeling during this time. And I think, just talking to your physicians about this, and every practice may be dealing with this a little bit differently because there's going to be different stresses in each practice and different issues that each hospital and different regions of the country are dealing with. So just remembering that your physician is still looking out for your best interest and trying to make decisions that will not reduce your outcomes.
Okay. That's well said. And I think in this pandemic, I mean, it's been the healthcare workers, the frontliners that have actually been the true heroes, people like you. And just we're always physicians first, that no matter who and what we are.
Yeah.
I'm a plastic surgeon, but I'm a physician first. And just like you, and I love you elegantly said that we don't want to compromise patient care, and people need to know that. And I think they can be reassured that you're not only compromising, but you're actually instituting superior care and actually fast forwarding what things should be already happening. Like I love what you're saying and doing about rapidly doing, the radiation and getting same outcomes. And I think that makes perfect sense because that people they don't want to drag things out, and they want to get through it, and they want to get their reconstruction, and they just want to get back to their lives.
Everyone wants to get back to their lives.
Right, and that's good. So how do they, if they have any other questions, or how do they reach you at UT Southwestern in radiation oncology or in the breast center? How can they?
Yeah, so my email address is asal.rahimi@utsouthwestern.edu. And I mean, I'm happy to answer any questions. I still think that there are a lot of kind of future directions that I'd like the public to know about.
Right.
Some of those include some of this hypofractionation, these ultra hypofractionation schemes that are coming out of Europe. So one of the things that they're doing, there's a trial called the FAST trial, and they basically have been doing 1 fraction of whole breast radiation on a weekly basis over 5 weeks. Preliminarily, that has showed some very positive results.
That's great.
They're doing another trial that has not. They've only showed very preliminary results, but basically they're doing the whole breast in 5 consecutive days. Some of the trials that we have here at UT Southwestern, we're doing the partial breast with a technique called stereotactic partial breast radiation.
Right.
We're doing it in 5 treatments to the partial breast with kind of just these very sophisticated techniques. We also have a trial where we're doing pre-op radiation, and that actually really kind of fits in with this whole COVID pandemic, because what we're doing in those cases for patients with early stage breast cancer is delivering 1 dose of radiation up front before any surgery. They start the endocrine therapy, and then the surgery would happen anywhere from like 4 to 6 months out, so several months out. And so then basically the tumor will just have time to shrink before they go to surgery. So, I think that we're going to start seeing some more pre-op trials and more of these kind of shorter courses of radiation, and especially partial breast, and maybe even shorter courses with ultrafractionation with whole breast radiation, and shorter courses with doing the lymph nodes as well. Okay,
that's great. I think that, you epitomize why this is a team approach. I mean,
absolutely,
breast cancer is a team approach, and you get to see experts like Dr. Rahimi, who's like phenomenal, and obviously places like UT Southwestern where there's an amazing breast care center. So I really want to thank you so much. And I think, as women are losing their jobs at an unprecedented rate, and they're losing their insurance, and, even before and after COVID, now more than ever, they actually need support. They need education, and if they want to have reconstructive surgery after their mastectomy, that's where, AIRS, our foundation, the nonprofit, helps women during and before this pandemic. And I just think that if you know that women are in need, just go to the AIRS Foundation website at airsfoundation.org, and you can apply for a grant, and we give out, thousands of dollars worth of grants every year, and we support and educate them too. And also check out this webinar. It's going to be obviously archived, and please share it. Because honestly, I've actually learned a lot today from Dr. Rahini on some of the new advances in radiation therapy, and we look forward to our next event soon on helping women with breast cancer. So, Dr. Rahini, very, very educational, and thanks so much. You were fabulous.
Thank you. Well, thank you guys for having me, and keep up the good work with this nonprofit, and it goes for a great cause. So
All right.
the community really appreciates that.
All right. Thank you so much. Take
Bye.
care.
Thank you. Have a great day.
Yep. Bye-bye.